again, my name is Sarah Weinstein, the Executive Director, and I'm so pleased to welcome everyone to our January event. So thank you for coming and spending part of your Sunday with us. We'll be talking about loneliness and social isolation and sharing personal experiences of the toll that loneliness takes on so many of our lives. We'll also be exploring how to cope and how to find meaning, purpose, and happiness in our lives. Loneliness can be really difficult to talk about. Actually, it can be difficult to even accept that we're lonely, let alone share those feelings with others. I want to recognize the bravery of our presenters for being willing to share their experiences and insights. And I also want to recognize the bravery of those of you in the audience today who are willing to overcome the stigma and say, I'm lonely. One of our wonderful members, Jean Fisher, wrote a beautiful reflection on loneliness and stigma that I want to share before we begin. Her experience perfectly illustrates why we're having this event today. Jean wrote, as someone who is living with aphasia and Alzheimer's disease, I'm learning more about the role of a new loneliness, the worst loneliness I've ever had in my life. I sometimes feel like maybe I'm the only one who is actually living with dementia, especially Alzheimer's. I can also understand why people are afraid to speak out. It is scary because we don't know how we'll be treated. There are many scary reasons to justify our fear. I've had several people come up to me with their truth and thank me. And this helps me share my thoughts. I still feel stigma, yet I'm getting stronger in speaking up, but not yet with everything. We need more people who are confirmed with a dementia disease of all kinds and all disease levels and all ages to speak up and to talk about their experiences. Yes, it's scary, and yes, stigma feeds loneliness. So thank you, Jean. All right, today, let's take a big step together by talking about loneliness. Let's reduce the stigma. So I'm really pleased to introduce our first speaker, Faye Girsh. You all know her as the founder of Hemlock Society of San Diego. And many of you probably know that Faye spent much of her career practicing as a clinical and forensic psychologist, as well as a university professor in psychology and conducting research. So it's very special to get to have Faye introduce the topic of loneliness today, and then we will transition into our other speakers. So let me pull up the slides, and then we'll have Faye begin.
Hopefully, without any technical difficulties. My background is sort of I picked out a slide that looks like really lonely in my own apartment. So here's a picture by Edward Hopper, I think the great artist of loneliness. Doesn't that make you feel bad? I had another one that that Sarah substituted that was sort of a cheerful, lonely slide. This is a really lonely slide, I think. A picture of, as Hopper's paintings usually are. Let's see. Slide, please. I am asking Sarah to move my slide. So this is Vivek Murthy, who was a former Surgeon General, and he was a Surgeon General during the pandemic when many of us experienced horrible loneliness because we couldn't go out of our houses or our apartments or even our retirement communities. We didn't see anybody for weeks on end. And I think, although loneliness has been around forever, and we have a member in North County who's written 7 books on loneliness quite a while ago. So this is not new, but the pandemic, I think, emphasized that. So the Surgeon General went around asking people how they felt. And even though they didn't put the word lonely on their feeling, they said they felt isolated, invisible, insignificant. I'm sure that must ring a bell with some of us who have felt that way, not all the time, maybe, but some of the time or a lot of the time. And he called that loneliness. Or people would say, I have to shoulder all of life's burdens by myself. And that often happens when you lose a spouse, or the children don't communicate with you, or you're really by yourself and you do have all of the responsibility of your life to yourself. Or this one, I think, which is a precursor to suicidal feelings. If I disappear tomorrow, no one will even notice. That makes me sad to even say that. But I think people have felt that way at times, and that's what he called part of the epidemic of loneliness. Okay, next slide. It's an arbitrary division into these three kinds of loneliness, but they sort of make sense. My elephants are not lonely, by the way. I love these pictures that I put up here. So do I have a friend? Do I have someone I can tell my troubles to? This is sort of an intimacy loneliness. A lot of people have casual friends, but do we really have a friend, someone that I can talk to? And that's much harder to find, especially when you've lost a close partner. Existential loneliness. Do I fit in? Do I fit into the universe? Do I have any purpose? Does my life have meaning? Does it have values? Do I have a mission? You can get a mission by joining the Hemlock Society, by the way. And a lot of us who are in the Hemlock Society feel it's our mission, by the way. Societal loneliness, that is, if I enter a room, will people welcome me or make fun of me or ignore me, or how will that be? What is my impact on society? I have to say that besides being 90 years old, I live in a retirement community, the V, which I love living in, and I've been here 9 years. And I will talk later about the benefits of living in such a place communally, because it is a really good antidote to loneliness, but does not answer all these questions that are raised by lonely people. Next. So our demographic, which is older people, and many women, by the way, and many people in our membership who live alone, and many of us who
just drag it over the right, and that should hopefully.
Many people who live alone and get older have chronic diseases and disabilities, like your vision goes, your hearing goes, your mobility goes. And when you go to talk to somebody, you have to scream at them. You can't see what's going on. You can't even read the computer. You spend a lot of the day staring out the window. And that does create loneliness for many people. And not all of it is curable. Next. I don't know how often you read this guy, but this to me is, this is not a guy who goes out to a hamburger and just enjoys the solitude. This is a guy who says, I'll have the lonely burger with a side of forlorn fries. Start with a solitary salad with quiet desperation. This guy's feeling this pain that he's describing of being lonely and desperate and forlorn. The Fusco brothers often hit it right on the head. This one makes me very sad to see this one. Especially even in our communal living here, there's often people who eat by themselves at a table for one. Maybe some people don't mind. A lot of people do. Next. So what the Surgeon General described in his report is that loneliness is not just a psychological problem. affects our mental health, but it affects our longevity. And it increases the risk of cardiovascular disease, dementia, stroke. I mean, I know these things. Don't you know these things as you sit alone in your room, that your thinking gets distorted, that your health doesn't seem right, that you do less exercise, certainly associated with the risk of depression. And we'll talk about that later with Pam. What comes first, the depression or the loneliness? A state of anxiety, like, why am I so lonely? Where are people that I could talk to? Do people not like me? Why am I lonely? And premature death, not just from all these other things that happen to you physically, but also because loneliness is associated with suicidal ideation. The Surgeon General said that being lonely is as harmful as smoking 15 cigarettes a day. You know, we're told not to smoke because it impairs our health, but we're not told not to be lonely. But that's worse. More harmful than obesity and physical activity. That's good to know. Since I am both there, physical and anyway, but being lonely is really contributory to not good health. So folks, if you're feeling lonely, we'll talk about some of the solutions here. Although I think my time is almost up. Sarah, next slide. Increases your risk of dementia by 50%. Can you imagine that? That's what we're all trying to avoid. Heart disease by 29%, stroke by 32%. These are quotes from the Surgeon General's report. I'm not sure where they came from, but I think you can take the, oops, this is not the slide I had. Okay. This is actually a slide that goes somewhere else, but this is a woman who has a caregiver. I'm sure it's quite expensive, but with her caregiver, she's not lonely anymore. Here's this nice young woman who seems to care about her, takes care of her. We have a lot of caregivers here at the V, and it does make a difference in whether people feel lonely or not. But what I'm wondering is there some people who are too old, too infirm, too isolated to never get over loneliness? I call it terminal loneliness. And I'm just wondering what you think about that. There's a lot of solutions for loneliness, but some people just can't take advantage of them. So should it be a reason to end one's life, to have aid in dying? Of course, in some countries, severe depression is a reason, and loneliness does lead to depression. So it may be considered a legitimate reason to have aid in dying, loneliness that you cannot seem to do anything about. In Canada and other places, if a disease is irremediable and causes unbearable suffering, that's a reason for end of life, assisted dying. And in many cases, what I call terminal loneliness is irremediable. And it does cause, for many people, unbearable suffering. We hardly ever hear about it, but I think the reality is it does. Next. Let me talk about retirement communities. I've been in mine for 9 years. I love being here. And this is one of the reasons, eating together. I just finished a wonderful brunch with 5 people at my table. It was so enjoyable. Besides, the food was wonderful, but the company was the best thing. And say hello to everybody, even a casual hello, helps to alleviate the loneliness you can feel by sitting in your room and not eating with people. I have to say that it's not easy, even at the V, to eat with people. It requires reservations and all kinds of things to do before you can eat with people. So a lot of people eat in their room, and that does not work for loneliness. Living in a retirement community is expensive, even though there are different models, rental only, month to month, that kind of thing, but it costs. And I would say to any young people listening, if you're planning to get old, save up now to live in a retirement community. I highly endorse it. Living communally is a good not perfect way to combat loneliness, but it works. Fitness activities, social activities, of course, are a very good way to combat loneliness. This is not my slide either. I don't know what slide this is, but I'm saying that this is activities that we have at the in retirement communities. Generally a very homogeneous population, which in our case, we have some very well-educated people, all people who can afford to live at our place, mostly white, and a lot of women, I think 3 to 1 women to men. A lot of old people, which as I get older is sort of shocking that I'm eating with people that might not be around next year or even next month. A lot of my friends are suddenly in the memory unit with dementia. A lot of my friends have died last year. And that part, living in a place like this, is very sad. People disappear because they're suddenly in the care center. People lose their personhood with dementia and their abilities to walk, to hear, to see. And that part is sad, living with old people. Some policies that we have here are isolating. This business of making dinner reservations is very hard for many people, hard for me even. And I presumably have all my marbles and I'm extroverted, but for people who don't have either one of those things, it's difficult. Sometimes a lack of common areas would be better if we had more common areas with coffee so that we could meet people more often. There are a lot of community building activities, fitness, art, lectures, chorus, movies. That's very good. And it does alleviate loneliness. You can go out of your room and go to one of these things that happens 4 or 5 times a day. Our meals are very good, very well balanced, and a good way to not eat, to eat, because many people who are alone don't bother to go grocery shopping, don't bother to cook for themselves. When I lived alone, I would have a jar of peanuts for dinner and that would be it. This is much better for them to do the shopping, the cooking, the chopping, and the serving, and we have good meals. I highly recommend it. We have intellectual stimulation from our movies, our lectures, and that kind of thing. And yet, with all that, of the 500 people who are here, there are many people who remain isolated, and you never see them. So retirement communities, yes, but not the perfect solution. Families are wonderful, but not, again, the perfect solution. This is not my family. It's my friend's family, Ken. He and I were together for 9 years. He's dead now. He died last year, and I don't have his family anymore. This is a very healthy family. They very care about each other. There's all ages here. They are intelligent. They are thoughtful. And they represent a variety of opinions. There are Republicans here, Democrats here. There are ardent Christians here. There are atheists here. So we don't get along on all issues. But it's very nice to see that they all care for each other. They all work. They entertain themselves. They know about the world. It's a very good family. And except for one brother, one of Ken's sons who lives in Arizona, they're all here essentially in the Little Mesa area, and they see each other and they care about each other. It's very nice. Still, in a family, it's possible to feel lonely and isolated and even alienated. I mean, some families will not welcome a new daughter-in-law or whatever for many reasons. So these are a whole list of things that I see my lonely friends do. I do myself. TV watching is probably the thing that most people do most often, which is very nice. It alleviates loneliness, but it's not interactive. You're passive. You may be learning something, but you're not interacting with people per se. A lot of people drink. Some people drink by themselves in their rooms. Some people go to bars because bars, in our society, the only place where you're permitted to really talk to people. It's a sad situation, but I remember being alone and when I was much younger, go to bars so I could talk to other people who were there. It was perfectly acceptable. I have a friend who was pretty lonely with his Parkinson's. He used cannabis a lot. In fact, I think cannabis gave him another year of living. It made him feel sociable. It made him come out of his depression. He felt really good using cannabis, and other people use other drugs. We'll talk about psychedelic drugs, and we'll talk later about antidepressants. Volunteering is acceptable. Everybody agrees that if you become a volunteer, that'll take you out of your loneliness, especially volunteering with young people, kids, but any kind of volunteering. Volunteering at Hemlock, we have a lot of jobs that people could do. And once you do that, you feel much better.
Hey, I hate to cut you off, but
yeah, go ahead, Sarah.
Yeah, we'll move on, and then we'll
Let's
return to coping strategies at the end.
Yeah.
All right. Thank you, Faye. And I'll have you introduce Donnie.
It is my pleasure to introduce my colleague, my friend, Donnie Moore, who is on our board, an end-of-life physician and a medical aid and dying provider. And Donnie, it's a pleasure to have you on our board and to be your friend. Go ahead.
Thank you, Faye. Feel the same way. And sorry, everybody, I have a bit of a cold today, so I'm clearing my throat more than usual. It's just for that reason. But as Faye said, yeah, I'm an end-of-life physician, and being in that role, I have sort of the really sacred position of interacting with people who are aged and seriously ill and terminally ill often. And so I get to hear about their experiences with loneliness and social isolation, and really explore how it affects them on a pretty deep level. So today I'm just going to talk a bit about why it's so important that we discuss this and destigmatize it. Some of the ways that it does affect people who are older and sick, and then also just some resources you might have at the end of your life to to better deal with loneliness and isolation. So next slide, please.
Can we see you in person or not? Oh, no.
Sorry, what was that, Faye?
I just wondered if we could see you in person.
Oh, like my
face.
My face. Can everybody see me okay? Am I clear?
Yeah, you're in the gallery.
Okay, wonderful. Thank you.
Okay.
So, among the other serious health effects that Faye discussed earlier in the presentation, suicide is something that's really pretty deeply coupled with loneliness. It's one of the strongest predictors of suicidal behavior. And people who are experiencing social isolation and loneliness can often end up in a cycle where they're very isolated, and that leads them to feel more sad, more hopeless, and then that can then feed back into further isolating themselves. And so it can lead to this really dangerous cycle that can often end in higher suicidal behavior. And the rates globally, but the rates of suicide among people 70 or older are the highest. So older people are at a rate higher than everybody else, often left with no options other, the feeling of having no options other than ending their life through suicide. And just again to sort of touch on our population, we find that social isolation and suicidality are more associated, or stronger associated in men than women. And that's something that also I just want to bring up, and comes up a couple times in the presentation, because I think that that's not really a population we often focus on, sort of struggling in silence with loneliness. Next slide, please. So again, more stats to sort of further that previous point. Older adults make up 12% of the population, about 18% of suicides. And specifically, a smaller subset of the population, white men 85 years or older, are 4 times likely to die from suicide than any other age group. So it's definitely, a pretty serious issue for older men. Next slide. And for many of our participants who are, in the San Diego area and in Southern California, you can kind of see how serious of an issue it is with these pretty high rates of suicide. And specifically at the bottom there, you see that for men, much, much higher than it is for women. So serious issue that, that I think that we can work to destigmatize and also to just discuss ways that we can come together and help support each other to avoid this. So for, again, in my work, I with a lot of people who are very critically ill, or just have a serious illness that they're living with on a day-to-day basis. And, in talking to people and having discussions about their lives, I find that, people do really rely on these social connections that they have and their support network when they're dealing with these issues. There's just things that you really need support for that, you can only really get with a sense of connectedness to other people. And they can help you work through these feelings that you're dealing with, these hopelessness, death anxiety, fear, and guilt. These are things that are really, really hard to work through alone without a support. And feeling isolated can just sort of amplify and magnify all these things that people are experiencing at this time. Next slide, please. So, people often reflect that when they're seriously ill, there's sort of these pieces of them that are taken away, and the parts of their network and their connectedness to other people are often lost as they're ill. The feeling that you're going through this alone and that there's nobody else, sort of that in the quote that Sarah read earlier, this feeling that you're in this alone and that nobody else really understands it, can again amplify these feelings of loneliness. And in addition to this feeling of emotional loneliness, I think that it's part of what Faye mentioned, where you start to lose your vision and your hearing and physical mobility that allows you to go out and socialize. All these actual physical limitations can then also amplify these feelings of loneliness. People are not able to really communicate and are not able to interact with the world around them in the same way that they used to be. And this can make their world feel really small and make them feel really isolated and alone. Next slide, please. So, I think that one of the things that also comes up in specifically in aid in dying is loneliness a criteria for aid in dying? So a lot of our members often wonder, what does and doesn't qualify. And one of the things Faye mentioned was the concept of terminal loneliness, which comes up as it's very prevalent among sick people and older people. And people say, is this a reason enough to qualify for aid in dying? So in the United States, it's not. You have to have a terminal, what's designated by physicians as a terminal illness with a less than 6-month prognosis to qualify. So unfortunately, loneliness and other neurological conditions can't qualify you alone. But just sort of a caveat to that is in other parts of the world, if you look at Canada, they're sort of expanding into that realm of considering it. They say that psychiatric disorders such as depression and personality disorders will qualify you. And as I mentioned earlier, and as Pam will go into, that inextricable tie between loneliness and sort of depression and how they amplify each other, so tied that in a way in Canada they are opening the door to sort of terminal loneliness as a qualifying diagnosis. So it is something that's being sort of considered and talked about in other parts of the world. Next slide. So when, just furthering on aid in dying, I think a lot of people assume that when people request it, it's just due to their symptoms not being controlled and they have inadequate pain control or some other symptom that's not being managed. But as you see the difficulty, your decreased ability to enjoy life, to get the quality of life, is really the thing that is really most driving people to feel like this is what they want and how they want to end their life. And I think that when you're looking at decreased ability to enjoy life, this is what I've found personally, is that not really having personal connections is is a huge reason why people, do request it. And it's sort of part of a whole nest of quality of life measures. I think there's like a lot of different reasons why, that you may not be enjoying life. And I think that not connecting with other people is a big part of it. I think that it's just one of those, one more quality life measure among many. Next slide, please. So again, under the context of aid in dying, if you're isolated, this is just for this one specific case. All the things that I find is really important to have other people supporting you and helping you on, going to appointments, paperwork, things that are really challenging when you're dealing with them alone and when you're feeling unconnected to other people, and or don't have people there to help you and support you. And so that can be really hard. They're already going through this process that's immensely difficult to work through. And then on top of that, it's the feeling that you're having to go through it alone and that it is much more difficult without support, I think amplifies the sort of trauma associated with it and makes it really hard for people. So I think it's something that we need to work on and talk through. And then just, for some resources to give some hope. We'll talk a bit more later about some strategies. But if you are at the end of life and you're on hospice, I think it's important to remember the resources you have available: social workers, therapists, volunteers, chaplains, doctors. There's a whole host of resources that are built into the hospice system that they're not going to necessarily be a full stand-in for somebody that's really close to you, but they also, that picture's face showed earlier, they can provide some support and some connectedness, which I think is important. They can provide you a bit of reprieve from the loneliness. So know these resources, and then even if you're not on hospice, reach out to your support groups. Your social networks that you have, community health centers. I think it's really important to know that there are resources out there and there is help out there and other people out there who care about you, and really it's important to lean into those. So now I have the honor of introducing Pam Impson, our administrative assistant for Hemlock, who's going to talk about her experiences with isolation, loneliness, and mental health. So thank you for bravely talking about that, Pam.
Thank you, Donnie. That was really interesting. We can go to my first slide. I'm going to talk about the connection between isolation, loneliness, and mental health, specifically depression. It's something that I was born predisposed to, and I have had episodes of depression throughout my life, including when I was a kid. I was first diagnosed about 52 years ago after the birth of my daughter. And I had 2 other episodes of major depression after that. And then I learned how to stay well until COVID came around and everything kind of flew out the window. I was diagnosed again with a major depression in 2020. So we can go to the next slide. That's just, I've lived alone for 23 years. Normally I don't get lonely when I'm mentally well. I work, I have my family close to me. I have a really great network of friends, and I even like doing things by myself. I don't mind going to concerts alone or events. I've been to the Art Institute alone. Movies or things like that. And what I found is that when you are by yourself, people around you, if you smile and you're open, they'll become your friends and include you in their conversations. Oh, and I should mention I'm on medication now. Next slide. So depression, it feels to me like being a little match girl looking in through the window at everybody celebrating. These are some of the symptoms that you should talk to your doctor if you're feeling 5 or more of these symptoms most of the day, every day for 2 or more weeks. Those are some symptoms that you may need some medical help to feel better. And we can go to the next one. This is the perfect storm. These are what predisposes some people to depression. Like I said, I was born with it. It's on my both sides of my parents' family, very heavily among women. Women are 50% more likely than men to have a depressive episode. Aging increases the probability, sorry. Other illnesses can be a risk factor. I know that hyperthyroidism can cause depression. And isolation and loneliness, it's a question of which comes first, the chicken or the egg. Loneliness can trigger a depression, and depression can cause you to isolate. So let's see. Oh, some of the other triggers that I didn't mention are grief and loss. When you're predisposed, I should explain the little picture there too. If you're person A, you have the risk factors. And then the yellow portion is stress. And it affects person B in a way that it doesn't overflow the cup. Whereas a person who has the links to the genetic link, the being female and that sort of thing, it can overflow the cup when you're under stress. And we'll go to the next slide. Let's see. The hurdles to getting help are on the left. For elderly people, it is not a normal condition. It's not a normal part of aging, but sometimes healthcare providers may think that your mood is just a part of getting older. And a lot of people feel that way too. They think that, well, I'm getting old, this is the way it is. The biggest thing, though, I think, is the fear of the social stigma of being diagnosed as mentally ill. I've had things said to me that were very hurtful by family and friends when I've been in a depression. Why can't you just pull yourself out of it? Just be strong. You'll wake up feeling better tomorrow, I'm sure. Or when I feel that way, I go shopping. And this just isn't the case. What they've found is that it's actually depression is caused by chemical activity in the brain. You can't diagnose it by a blood test or a brain scan. But what's interesting is that the brain scan of a depressed individual is different than their brain scan, that person's brain scan when they're not depressed. I hope that's not confusing. But the main thing for help that I think that I want to stress on is if you think you may be depressed or if somebody you care about is, make an appointment with your doctor and they'll screen you. If they need to refer you to a psychiatrist, they can do that for you. Medication has worked wonders for me. And I can talk more about medications another time, or if you have questions, feel free to ask me. There's other types of therapy, what I call talk therapy, group therapy, occupational therapy, and that sort of thing. Depression can lead to a crisis. And if that's the case where a person is feeling suicidal or like hurting somebody else, then call 911 or go to the nearest emergency room. Oh, and I want to mention some famous people in history that have had depression. Winston Churchill, Abraham Lincoln, Beethoven, Virginia Woolf, Georgia O'Keeffe, Martin Luther King Jr., Ernest Hemingway, Diana, Princess of Wales, Sir Isaac Newton, Mark Twain. So I'm among good company, I guess. We can go to the next slide. these over the years, I learned that I have a condition called persistent depressive disorder. And what that means is that I experience depression light. It's not as severe as major depression, but with PDD, it lasts for 2 years or more, whereas a major depression can run its course in 6 months or even a couple of years. But PDD is kind of the demon on my shoulder, and I've learned how to stay well, mostly until COVID knocked me off my feet. And that was the isolation. But my doctor recommends sleep. I can't drink because I take medication, and that's a depressant anyway, so it's really not a good thing. Exercise is super important. Taking my medication on time and regularly is important. And then frequent exposure to sunlight. There's a form of depression. The initials are SAD. It's called seasonal affective disorder. And it's triggered by a lack of sunlight. People mostly experience it in northern climates and during the winter time. So
And
on
Pam,
right hand, I'm sorry, am I running out of time?
you have a couple more minutes, but I know you and Faye wanted to have a discussion as part of your presentation. So you have about 5 more minutes for that.
Okay, thank you. I appreciate that. I do recommend, if you can, get a pet if you're living alone, like I am. They keep you, they kind of force you to participate in life. You have something that's relying on you for food and affection and hygiene. So it's a good thing to have if you're mentally unwell. We can go to the next slide.
Pam, I wanted to ask you some
Sure.
questions. Go ahead.
Go ahead, Faye.
Well, it's very interesting to me what I learned from you, and that is how intricately involved is depression and loneliness. Although in your case, it's clearly 2 separate things, I think. So your depression caused you to isolate yourself from others, except your cat. And when you didn't feel depressed, when you took the medication, you didn't feel lonely. You could socialize with people. You could be in solitude, have solitude and enjoy that. And loneliness was not a factor once you felt okay. Am I clear about that? Or
Yep. That's exactly right. During the COVID, the early months of 2020, I didn't see another human being for a few months. And I was starving for touch, especially from my granddaughter's hugs. It just really, really, really was a very bad thing for me. I did not expect it at all. And what's really sad about depression is it comes on so slowly and insidiously that you don't recognize it, and you're suffering a lot longer than you need to.
so in that case, your isolation did lead to an exacerbation of your depression.
Yes, it caused a major depression, actually.
Yeah. So
Yeah.
it's very interesting
Part-
link here.
Yeah, part of it. I also lost my job. There were other things happening at the same time, but
Yeah. And then you do have this very close connection to your daughter and granddaughter,
definitely.
which during COVID you couldn't see
Right.
them. You could communicate with them, but I mean, you're very lucky to have that connection that a lot of people don't have.
I was really afraid of catching COVID. I don't know about anybody else, but and I'll admit something. I hoarded toilet paper, and when my daughter needed some, I handed it over the back fence to her on the end of a broom handle in a bag. So I mean, we were, it was just crazy. It was a crazy time. So yeah, it's
Loneliness is not
first the loneliness or the depression, or the depression and the loneliness. It's
Right.
hard to recognize it when I'm in that condition.
Right. But it's so nice that a pill makes you feel normal. I mean,
Yes,
that's a blessing. And it's so interesting that loneliness is not in the diagnostic and statistical manual that we look up when we make a diagnosis. Depression is. And we
yes.
know if you have so many symptoms for such a long time, that's a diagnosis of depression. And then you can treat it with a pill or
Yeah,
combination of pill or psychotherapy, whatever. But loneliness is a whole nother a phenomenon that's very subjective. And the way it's defined in many cases, it's, well, by Dr. Murphy,
I'm
is that
glad
it's
you
a
mentioned
subjective
that,
state.
because there are 5 different subtypes of depression, and the symptoms are not the same for everybody. So I'm only talking about my personal, I'm not qualified to talk about other, people's depression or what medication they might need to have or something like that. And I have had other types of depression too. The big thing I want to talk about is standing up to the stigma too. We have some celebrities who have become very outspoken about it. Lady Gaga is one of them, about her depression. People, you'd be surprised. They have everything in the world going for them. Money, talent, intelligence, looks. But yet, they suffer this depression, because it's not a choice. It's not something that you just let go of your sanity one day. It's not a weakness. You should not see yourself as a burden to other. And it doesn't mean that I am a failure or a freak. I love this quote by Michelle Obama. I won't read it to you, but it's there on the screen. And I think it's a very sympathetic and empathetic way to look at depression. And we'll go on to the next slide because I'm running out of time. So 35% of people, and I think it's probably higher than that, it's an estimate, have depression and are not receiving a treatment. A lot of people are not receiving enough treatment. I see taking care of my mental health as an act of self-love. And it's very important for a good life and a good death. I don't want to face the end of my life when I'm controlled by my depression. I want to be mentally healthy when I reach that point. So I do, I embrace my solitude when I'm alone. And I also make time for living. Oh, one other thing I want to say about suicide, the self-deliverance methods, I cannot recommend what the do-it-yourself. Taking an overdose of pills or blowing your brains out or what else, poison or hanging, because a failed attempt at suicide is a horrible thing. With medication, you can end up having your stomach pumped, which I have had done. It can cause, when you come out of it, you can have amnesia, which I experienced, loss of some of your brain functioning. I had a very good friend who shot himself in the head and lost the use of one eye. His face was disfigured. And of course, when he was treated for his depression, he had that extra burden of what did I do to myself? How, the guilt of that. So I would recommend it, for people who want to, self-deliverance, go the final exit network route or medical aid in dying. Do it with the tried and true methods, and don't do it the messy way. I haven't horrified anybody with that. We can go to the next slide here.
Thank you, Pam. That was very courageous, very
Janet
helpful. I
Hager,
really appreciate you doing that.
Our interim president and treasurer for the Hemlock Society of San Diego. And she's going to talk to you now about her perspective on isolation and loneliness. And take it away, Janet.
Thank you, Pam, and thank you for for being so vulnerable and sharing your experience. That was very powerful. Sarah, I know that unlike everybody else, I don't have slides prepared, and I'm wondering if it's possible to stop the screen sharing, just because I think if you see me in real time, face to face versus looking at my photo, it might be better. So I recently finished reading the book, The Last Doctor by Dr. Jean Marmorio. And she's a medical aid in dying provider in Canada. And she makes points in her book that really relate to loneliness. And some of these, she shared that data gathered in Canada about those requesting medical aid in dying, which you'll also hear me say MAiD, the acronym for medical aid in dying, showed that after the first few months of the COVID pandemic, requests for MAiD increased. For the elderly, living in isolation had devastating effects. People declined cognitively and physically. Because what's the point of living if you're not able to hug loved ones or sit with a fellow human and talk face to face? And I think one of the best sentences in the entire book was that the values of living often lie in a simple connection to other human beings. That's pretty powerful. I personally found this out when my husband David died from pancreatic cancer at the end of 2019. And even prior to this point, we together experienced some loneliness. So Donnie shared with you, people with a terminal diagnosis often feel more lonely because of their illness. And David battled his cancer for over 6 years. And there were many times during those 6 years that he was immunosuppressed. So we limited our activities and interactions with others to keep him from battling both the cancer and some viral or infectious illness too. While our family and good friends were attentive, we often felt out of touch or irrelevant. They were doing fun and interesting things. We were going to doctor's appointments, treatments, procedures, etc. And we had very little of interest to add to conversations. So we really felt like we suddenly were very different from our friends and family. When David died, I entered a world of immense grief and loneliness that was crushing. Initially, I could be with other people, but I still felt alone because David wasn't with me. We were high school sweethearts. We had been a couple since I was 16 years old. We had no children. We had not only lived our lives together, but we had worked together for nearly 20 years. So we were super connected. And not long after David's death, the COVID-19 pandemic began, and the forced social isolation impacted my loneliness. Initially, after David's death, I sought the help of a clinical psychologist who provided me with tools to help me find comfort and to examine how I might re-enter the world as an individual instead of a couple. After a few months of one-on-one sessions with a psychologist, I graduated myself to a support group for people who had lost their spouse or partner. This group work helped to validate the ways I was feeling and thinking, but it also provided me with ideas on how to improve my situation. What I came to realize was that I was the sole driver of my future. I needed to examine those things that would provide meaning or purpose to my life, connect me with others, and provide the potential to be happy again, or at least to be content. Once I'd finally come to that realization, and yes, I am a slow learner, so it took me a while, then I had to take the next harder step, which was to actually put some of these ideas into actions. I decided that my first step was to begin each day with gratitude and consciously list all that I had to be grateful for in my life. This may sound hokey, but it actually helped me. I figured out where my passions in life reside and ways that I could be of service in those arenas. So I began by being a fundraiser for the Pancreatic Cancer Action Network by hosting an annual walkathon on the anniversary of my husband's death, raising as much as $10,000 for this single event. I joined a team at the University of California, San Diego to improve the experiences and outcomes for those living with pancreatic cancer. I am the patient / I'm actually the caregiver in this situation, advisor on the team, providing input about those areas where their care could be improved. I joined the board of directors for my homeowners association to serve the community that I lived in for over 35 years, which allowed me to become better acquainted with my neighbors. I began volunteering in the rehab department of Scripps Hospital. I'm actually a physical therapist by training. And so that's a really fun place for me to spend time. I became a member of the Hemlock Society of San Diego to work on end of life and right to die in this right to die movement. And I became more and more involved over the years with Hemlock's mission. And I became a founding director of A Better Exit, which is a nonprofit seeking to expand California's End of Life Option Act to allow more suffering individuals access to medical aid in dying. I never envisioned myself doing any of these things, but I made a commitment to myself to find ways to be of service to others that would bring purpose and fulfillment back into my life, so I could combat the grief and loneliness that wanted to weigh me down and break me. And that's my story.
That's amazing, Janet. Very helpful, I think, to people. You know, we have a psychologist on board here, Dr. Joe Cascani. I'm probably not pronouncing your name right, Joe, but I've known Joe for a long time. We're both psychologists in the community. But Joe's sort of special because he's a geropsychologist, which, if you don't know what that means, it means he deals with older people. If I say he's a geriatric psychologist, that would also describe his age, which I don't know what his age is. But Joe, do you have any comment on all of these things that you've heard today?
Yes, Faye, thanks very much for that intro. I'm really happy to be a part of this, and I thought the presentations, all four of you, were just great, 5 of you. So I've worked with older adults my whole career, as Faye said, primarily in long-term care settings. And I think I see someone in the audience who may have worked with me over the years. If it's the same person, Patricia Green, I recognize your name. Okay, forgetting naughty. Anyway, working with nursing home patients, I've learned a lot. And a couple of things, important lessons. Number one, we are not our bodies. In other words, that may sound strange, but we can decline, we can lose a leg in an amputation, we can have a stroke, we can go through a lot of physical things, but we still have the I in there, the me in there that can stay positive no matter what gets in the way. And I think that's important. We may, again, decline, we might fail in so many physical ways, but we still have the opportunity to keep an upbeat attitude no matter what gets in the way. And I know that's easier said than done, but I think it's important. Number two, we all have a bottomless reserve of spirit or grit or resilience, whatever we want to call it. It's always there, no matter what's going on. And I remember talking with so many patients who would throw their hands up and say, I'm done. I can't walk anymore. I can't drive anymore, whatever. And I would always look at, there is this reserve. As long as we're taking a breath, we still have something that we can use to push us forward. We still have that fire and determination to help get over those hurdles. And I think that's important. Just another quick comment. When we look at depression, Pam, you did a great job talking about depression, but the way I look at depression is that we want to look for exceptions, because whenever we're depressed, all we see is what's wrong. We see the disappointments, we see the failures, we see the losses. It's like we're wearing blinders. And because of that depression, we don't see the whole picture. So to me, the treatment, the recommendation is, let's take off some of those blinders and let's look at the whole picture. Let's see some of the positives that we're not seeing when we're depressed. Kind of like taking the blinkers off. Horses wear blinkers. So we take the blinkers off and we can see the good. It's so easy to focus on what we don't have. It's so easy to focus on what we cannot do anymore. What's wrong, all the failures. But let's take those blinkers off and let's recognize that we still have many positive things. We still have the opportunity to look forward. We still have the opportunity to interact, tell a joke, take care of ourselves, whatever's going on. We still have those positives, and we have to be careful we don't get pulled into that depressed place, because it's a vacuum and it keeps us sucked in. So let's try to recognize that I don't need to stay here. I can look at what's good. I can look at what I still have, and a lot of that. So yeah, just thanks for those couple of minutes. But I love to contribute to conversations like this, and I love to talk about inspiration and education about aging. So Faye, thanks very much for this opportunity. Appreciate it.
So, Joe, the point Pam made was when she was depressed, she really didn't seem like want to do anything.
Mhm.
And the medication that she takes now
Mhm.
has enabled her to look at all the positives, do things, not feel lonely.
Mhm.
Does that seem like a logical solution to you? It certainly does to Pam. It does to me.
Yeah, no, I think it does. I think the medication does offer that boost. It offers, how to address some of these symptoms that we feel. But there's also the need to, take those steps. And I call it, we can't wait for people to knock on our door. We have to knock on somebody else's door. We have to initiate that activity. And, Pam, I think you said it well, you have to kind of be ready to take the initiative on a lot of things. We can't wait for the fixes to come knocking on our door.
And I think what Janet said too is what she did sort of deliberately to get out of her sadness, her grief, was to do all this volunteer work and be on the board of this and that, and her homeowners and Hemlock and everything else. And she really did pull herself up and say, these are things I must do so I don't feel so bad about losing my husband.
Yeah, that's a good point. Yeah. And I would often ask a patient, how will you know when you're not depressed anymore? And they would say, well, I get up tomorrow and open the curtains in my room and maybe go down to the dining room. So I would say, okay, tomorrow morning, I want you to get up, open the curtains and go to breakfast. So it's what we call behavioral activation. We put ourselves into the behavior. That's what changes a lot of the emotions sometimes. We can't wait for the emotion to lift and then do the behavior. It's the opposite. I think we engage in these behaviors, and that's what changes the mood and the affect. So
Right. And I know I personally found that because, every day it was hard to motivate myself to get out of bed and go do something. But as I made myself do that, then it became, much more comfortable and normal, and eventually the feeling that goes with that started to accompany the actual doing of it. I did start to feel happier, and I did start to feel more engaged when I made myself go and do these things.
Yeah. Yeah, I think that's good. That's important, Janet, because the behavior can change the mood rather than the other way around. Yeah.
Joe, we seem to be lapsing into talk about depression, and we're supposed to be talking about loneliness. How do you see the distinction?
Yeah, well, I think, as we've said, loneliness can contribute to depression. A lot of what goes on in our heads also exacerbates that negative feeling. We can be around a lot of people and still feel lonely. It's not necessarily being away from people. It's not necessarily that social isolation doesn't in itself cause loneliness. And I think a lot of it, again, I use this cognitive behavioral approach, and what's going on in our head is going to drive a lot of our mood and our behavior. So if we catch ourselves from that negative thinking, like it's not going to get better, I don't have any solutions, I don't have any hope, I don't have any outlets, that's going to contribute to it. So if we look for the small steps, what am I doing today that's better than yesterday? What can I do tomorrow that's better than today? Taking these tiny turtle steps. And we really have to, I think, kind of pull ourselves up and keep pushing forward. And I think loneliness, we talked about it contributing to dementia. We have a lot of modifiable risk factors for dementia too now. There's probably a dozen conditions that lead to dementia, but it's not the irreversible kind like Alzheimer's. These are preventable dementias. So loneliness is one of the culprits, just like depression is. it's hard to, I mean, I'd be happy to answer other questions. I don't know if I can answer that better than what I've said, Faye. It's just what's
Yeah.
going on in our heads. Yeah.
I noticed Pam made a comment about medication doesn't cure depression. Is that what you said, Pam?
Mhm.
Say that,
It
explain
can
that.
manage your symptoms
Mhm.
until it runs its course.
Mm.
It doesn't cure. It's not an overnight thing either. It takes time for the chemicals to reach a therapeutic level in your blood. It can be trial and error, finding what works for you or the combination that works for you. So I don't want people to think it's a panacea. It's some people it doesn't work at all for.
Yeah.
Yeah, good.
Yeah, I agree, Pam. It does help with the symptoms. But it's in and of itself, it's not gonna keep pushing us forward. Yeah.
Can we go to our audience? I bet there's some people out there who've been lonely. You think? I think everybody has been lonely at one time or another. The question is what to do about it and how pervasive it is in your life. And does it lead to wanting to take your own life? There's Sharon. Hi, Sharon.
During the beginning of 2020, during the COVID, I was diagnosed with cancer on top of the COVID, on top of getting radiation and all that stuff. And what helped me hasn't been discussed yet, and that's the hotlines and the warm lines. Those were very beneficial for me. I knew when I was getting lonely, I could feel it. I needed someone to talk to, and I needed it not to be family because I didn't want to burden them. So I got on the internet and I looked for warm lines or hotlines, and I called 211, and I got some of those numbers and I called them, and it was just a voice on the phone that I could talk to for 10 or 15 minutes that just got me through that particular 15 minutes of life.
So this was not an intimate friendship or anything like that, but it was somebody to talk to when you needed it.
Correct. So I'd say also look at the warm lines and the hotlines. You know,
I never heard of warm
consider
lines.
that.
What's a warm line?
A warm one, usually the hotlines are partly connected to like suicide hotlines, but the warm lines are you're in anxiety, you're in stress, you're lonely, whatever. They're a warm voice on the phone.
Huh.
And they're free.
And you go to the internet and you look up warm lines, hotlines?
Yes.
Everybody should know that. That's really good. Thank you.
And if you forget about that, call 211. Here in San Diego, I don't know where it is in other states or cities, but I know in San Diego it's 211, and they can give you some resources, because if you don't have the money or you don't have the energy to walk out the door, you might have the energy to pick up the phone.
Boy, does anybody know about that? That's really good. Thanks, Sharon.
Sure.
No, you're a very independent person. I know you've been through a lot with your sickness, and you still maintain a lot of independence and social contacts. So good for you.
And I'm not afraid to say I'm lonely.
That's people. I mean, that's what the Surgeon General pointed out. People are afraid, ashamed to say they're lonely. Thank you, Sharon. Yeah.
Yeah, and Sharon, thanks for also bringing up that it's different for everybody. What's going to make you feel less alone? That it's not always like your loved ones and your family. Sometimes that's going to Faye's point earlier. You can be with people. You can not necessarily be alone and still feel lonely. So yeah, for some people, it's not going to family and friends. It's just a nice, kind voice. Yeah, thanks for sharing that. Super valuable.
And Pam was courageous enough to say that her depression, not her loneliness, her depression, I guess, caused her to consider taking her own life. Fortunately, she didn't. And we're very grateful for that, Pam, by the way.
Well, I tried, Faye.
You tried, yeah.
Yeah, that's how I ended up in the hospital.
And
But
I don't know
lucky that
what
someone found me.
intervention, how was the intervention happen that you were saved?
The person I was living with came home early.
So, and of course, Pam says doing things like that, not do-it-yourself methods. There are good do-it-yourself methods, but those other violent methods, uncertain methods, do not do that. do not do that. I mean, read Final Exit or do something else, but do not take poisons that you don't know what they are, shoot yourself and shoot your eyes out and do that stuff that when you're feeling really bad, call hotline, warm line, call somebody, do something. But don't jeopardize your life that way, and especially in such a violent, uncertain way. Anybody else? Who's taking the chat line? Donnie, are you?
Yeah, I've been sort of manning it a little bit. I think an interesting point was just made by Letitia Rogers. I felt that some people seem to be afraid that they might catch someone's loneliness. I think that's kind of an interesting point. I don't know if anybody's sort of felt that themselves or maybe felt that reluctance in other people. But I think that is something interesting.
I've sat with people that are very lonely and depressed, and it's a downer.
Mhm.
It's not contagious, but it's a downer. It's interesting that the first slide that we showed, that Edward Hopper picture of the woman in the cafe eating by herself or whatever she's doing, I changed that to a cheerful sort of round ball of guy being depressed. And Sarah changed it back again because I thought that picture was a downer.
Mhm.
And I didn't want this whole session to be a downer, but it's not contagious, but it's hard for people who are feeling bad to have somebody to talk to and not bring them down. Bill, you have two hands up. Does that mean you really want to talk? You're not even connected here. Unmute yourself. This is Bill Simmons, a well-known attorney around town that talks about advanced directives, has a very good website. Giving a little plug while you connect yourself here, Bill.
No, I don't want to plug myself. But I have a question for Donnie that's on the chat. He said more suicide's more common in older men than women by a factor of 4. And Pam, I think it was said that suicide is more prevalent in dementia is more prevalent in women than men. So you've got more men committing suicide and less men being depressed. So to me, that data is a little inconsistent.
Dementia, I think she said.
I'll tell
Yeah,
you one thing,
depression, not
women get
dementia.
postnatal depression and the changes that we go through in menopause, the hormonal changes can trigger depression. Men, I guess, are more active about ending their life, and they tend to do it in a violent way. It's the old saying, women take pills and poison and men use guns and ropes. What were you going to say, Donnie? I'm sorry.
Oh no, it's fine. It's a line along with that women are more depressed overall than men. But I sort of touched on this in the chat too. But there's a whole host of like different risk factors that change.
Yeah.
What somebody, what the depression, how that plays out in different demographics. But I think the important distinction is what Pam just said, that more women than men attempt suicide.
Right.
So, more women are depressed and more women are attempting suicide, but far more men are successful at higher rates than women. So men
They have
are
access to firearms.
Yep.
access to firearms is a big part. But just so men are having suicide at higher rates, but women are attempting it at higher rates and have higher depression.
White males over
Very
80.
interesting.
It is.
Hey, I'm
Most
glad
of
you
our members are
mentioned
women.
that because in our firearm death statistics, it's actually suicide is at the top, rather than mass shootings or gun murders. It's actually suicides that top the list in our gun violence rate.
I see our friend Barbara has her hand up. Hi, Barbara.
Hi, Barbara. You're muted.
Hi.
It was
Yes.
perfect.
No, I'm not. Two, hopefully quick comments. One to Dr. Moore. I would just have you, in seriousness, add one word to one of your slides where the slide is talking about having a positive dependency on friends and family. I would seriously put the word pet also. And I've lived alone, not lonely, but alone for a couple decades, and only had a cat for 6 years. And I've got to say, the addition of an animal that you actually form an emotional relationship with versus they're just a decor in the apartment is amazing. And I laugh out loud at the antics or at the surprise of suddenly having this thing jump over my body onto the bed. I mean, the spontaneity that comes into the life of an alone person with a bonded pet, I think it can't be overstated. That's one thing. The other thing is no one has commented on this form of aloneness. It was alluded to with loneliness in one of the lists. But what I'm getting to experience, I like living alone. I could not live, Faye, in your lovely, lovely building. I was in a high rise downtown that could be sort of like your place. And I don't want to be on as soon as I get in the elevator or have my eyes lined or be ready for interaction. No, I like being alone, and then I like going into a community by my choice. So I live in Little Italy. I can go into the cafe, and I'm not necessarily interacting, but I feel like I am in a community as I watch the dog and the owner come for the coffee, whatever. However, in the last 8 years-ish, I am having a new situation. My genetic predisposition for hearing loss is just about at its end. Lost all hearing in one ear and residual in the other. Thank God to Apple that went into a sponsorship with high-end hearing aids and provided Bluetooth. So I get to hear all of you perfectly. And otherwise I'd have to be about 4 inches from your mouth with my right ear only. Very awkward. But add that with the fact that I am experiencing increased memory loss to the point that I nagged my neurologist to the point of giving me the long-term test to see if I had any form of documentable dementia, and came out no, that it is just memory loss. Well, the world gets little. So even though I like living alone, and I said I like going into a group, my options for a group, I have to work hard to figure out what they're going to be if they're live, because with memory loss impacts a number of things about interactions, and then not hearing diminishes so many. And so like Edgar Allan Poe's walls that are coming in and in, I'm definitely feeling that. So I work at not getting a depression, not a clinical depression, but a momentary depression, at not having a choice of whether I get to interact or not because of situational things. So that's another type of isolation, you know. So thank you.
Thanks, Barbara. I didn't talk about that, but I thought if we had another person on our panel, it would be somebody who has a hearing loss, a vision loss. We have plenty of mobility loss. We have plenty of those here at the V. And that isolates people further, even when you start being able to not drive and that kind of thing. So your hearing loss, I know how isolating that is and how you've overcome it all these years. Remarkably. I mean, you go to Italy and you do a lot of things that most people don't even do. with your hearing loss, but now you're feeling it, that in addition, and your memory loss. So now a whole another set of coping skills has to evolve for you. Yeah.
Yeah, thanks so much for sharing that, Barbara. Sharing your stories. I think this is all about making people feel alone and feeling connected and feeling like other people are going through it, and it's super helpful. And also, I think I would definitely add in something about pets, because I assumed that fur babies were, friends and family, but I think that they also deserve an extra little distinction in there. So I'll definitely change that in the slide.
What I didn't talk about, which I have talked about in other presentations, is robots. Because in Japan, as you know, the population is aged. They have more old people than we do, and they have no help because they don't have immigration. And so they have relied heavily on robots, and they have robotic cats. And so no cat litter is involved or cat food or anything else. And they purr and they do things that maybe they don't jump over to the bed. I don't know, but people are very not satisfied, but a lot of the loneliness dissipates because their robots do things for them, help them get out of bed, provide food and purr, depending on what robot they have. So we may come to that sooner or later, probably sooner. I mean, I've had meals served to me by robots, but we have plenty of helpers so far, but we're going to run out of them as we have more and more older people. So look for your pet robot. In fact, you can go online and buy them. You can buy a pet, you can buy a working robot, and they range from a couple of $1,000s to $35, $40, $50. So there you are. Anybody on chat? Joe, you have anything to say about disabilities and loneliness?
I was thinking, just to go back a few minutes about suicide. I remember seeing research about the incidence of suicides in older adults, and this was always very striking to me, that the success rate for those who attempt suicide is much higher in the older adult population than in the general population. We've always heard, or we've said that in the general population, suicide can be a cry for help, a legitimate cry for help. I'm really suffering, I'm really hurting. And the success rate isn't always up there, but for older adults, it unfortunately, for those who want to end their lives, it's not a cry for help anymore. It's really this intent to end their lives. So I think when we see signs in our population and 65, 75, 85 and over, suicidal signs, then it's serious. It's always serious, of course, but
there's a movement in the right to die, among the right to die people, to have old age as a criterion. I've seen it in several places now. There was a Society for Old Age Rational Suicide out of England. There is a society called Completed Life Initiative, which believes that when you think life is completed, then you should be able to have a gentle, peaceful death. And I see it coming up in a forthcoming legal meeting that's happening in March. When a lot of people go to Switzerland for help in dying, as Christy knows, as she took her mother there. And they helped a 104-year-old man who did not have a terminal illness, but he was ready to die. And that was the first instance I know where legally help was provided just because the man was old and wanted to die at 104. So I think you'll see this coming up in the right to die movement, as we have so many older people in our environment. It's very interesting to me that Japan doesn't have any laws regarding aid in dying. Even they don't have living will laws, and yet they have this aged population. We have an aging population. They have an aged population.
Faye, your next movie next month out of Japan,
yes,
is on having that choice as an older person and having a peaceful choice. You just go in and register, and there you are. So anyway,
Thanks,
I think it's interesting.
It's Plan 75 Barbara's talking about.
Yeah.
And of course, when we showed, what was the other movie? Soylent Green, You remember Soylent Green? A lot of actually we showed that a long time ago, but it's a classic. And it happened to be Edward G. Robinson's last movie, but he goes into a place where you can say, I want to go home, and they ask you what's your favorite color and your favorite music, and you go to this room and you see beautiful slides of how the world used to be, and and this nice sweet young thing gives you a nice injection and you die and you become a wafer. But that's another thing. But yeah, thanks, Barbara, for mentioning our forthcoming movie, which, Sarah, you know what date that is? Can't remember.
Yes, it'll be February 18th at the City Heights Library here in San Diego at 1:30 p.m.
Thank you.
I know we're out of time. I also saw Patricia has her hand up, but just quickly about Japan. I think that in Japan we have a flatter curve. We don't have the, like in Western, like in US, where there's the steady decline because of chronic disease. In Japan, I think people tend to stay very, very healthy up until the end of life, and then it drops off. So I think that, it's called flattening the curve. We'd like to get there in the US, but we're not there yet. So in the US, we see a gradual steady decline, but not so in Japan. That might be.
Is that right?
Yeah.
What do they do besides eat fish that makes them like live and then die?
Well, until our processed foods is taking over, but until then, I think they tend to eat healthier and they're more fit, physically fit. Lower rates of diabetes, lower rates of obesity. So I think it's a fairly steady, healthy rate until their end of life.
That's the ideal curve.
Yeah, no curve. Steady diet. Yeah.
I mean, around here, people do that. And people are so shocked. We didn't think they were sick, and all of a sudden they're dead. And that's quite different from our usual rate of people being in the care center for months and then dying. Yeah.
Well, everyone, thank you so much for attending. This was really a wonderful event. And I just can't thank all of you who shared enough, because it really makes a difference to hear people's stories and to know that we're not alone, and to have ways to face these experiences of loneliness, depression, social isolation. So thank you. We really appreciate it.